Chavez here, and I'm going to try something new today. Given the recent COVID-19 stuff and the social distancing that we are supposed to be practicing, unfortunately we've canceled all of our trainings, and including our medical training. Recently I've noticed that, or I've heard that we've had a lot of cardiac patients, and there's been quite a few questions regarding chest pain, aspirin administration, acute coronary syndrome, and etc. And I've done the best I could to explain this to individuals, but then I got thinking, it's really been a while since we've done a cardiac emergency class. In fact, it had been since we've gone from MFR to EMT. A few years back, I taught a section of it. So it's been a while, and we need a refresher, and hopefully this will bridge the gap and we can go forward. If you guys have any questions afterwards, then please send them my way. Okay, first things first, I'd like to share some statistics with you all. I got this from the CDC a few years back, so I'm sure numbers have changed, but that's still pretty relevant, and I think it really impresses the importance of learning about cardiac emergencies. So as you can see, a lot of people die of heart disease and coronary artery disease every year. I think those numbers are pretty big. Every 34 seconds, an American dies of a heart attack. And every 60 seconds, an American dies of something related to heart disease. Now, this is what I thought was quite interesting. The 47% there at the bottom, that's actually going to be how many cardiac arrests actually happen pre-hospitally. So that's a very big majority of the cardiac arrest patients that are happening pre-hospital. Those are patients that we are actually responding to, which brings me back to the high-performance CPR. That's why we thought it was so important, other than the fact that it's protocol now. But even before it became protocol, we thought it was so important to teach our members high-performance CPR. And I think our numbers really show that we've been doing a pretty good job of handling those type of situations. So nice job there. Now, before we talk about the actual pathophysiology of cardiovascular emergencies, let's talk about the anatomy specifically to the cardiovascular system. So the heart is the big powerhouse, right? That's the pump. And the heart is comprised of 4 chambers. The 2 atriums are on top and the 2 ventricles are on the bottom. Now, the left ventricle is quite a bit larger than the right one. And the reason for that is because it's pushing all that blood throughout our body, right? And so that's going to be the high pressure system. The left ventricle is going to be the high pressure system, and it's going to push that blood into the aorta and into the arterioles and arteries throughout our body. Eventually that kind of gets narrowed down into the capillaries, and that's where the gas exchange happens. That's where the oxygen-rich blood gives its oxygen to the cells in the area. Those cells then give that blood carbon dioxide to take back into the venous side and back into our lungs so we can breathe that out. It's a pretty ingenious system, and it works pretty awesome. So before we can actually talk further about cardiovascular emergency, I really wanted to look at arteries and veins because we haven't really talked a lot about arteries and veins. So you'll notice in these 2 pictures, the arterial side is on the left, the veins on the right. Now you'll notice that the arteries are quite thick. So the arteries have to be thick, and that's because it's a high pressure system. So the muscles in the arteries allow it to constrict and dilate, and it also allows for that high pressure blood to be flowing through there. Now you'll notice on the venous side, that vein, it's not as thick. Does it have all the same muscles? Yes, but it's just not as thick, and it doesn't have to be as thick. The venous side is a low pressure side. In fact, it's such a low pressure side that there's multiple valves, one-way valves that run the whole length of a vein. And what that does is that prevents from backflow. Because it is a low pressure side, it really relies on those one-way valves and our body movement to help get that blood back into our heart. It also really relies on our breathing. You remember, when we take a deep breath in, that kind of causes a negative pressure in our thoracic cavity. Now that thoracic pressure, along with the one-way valves and along with our muscular movement, helps suck or push that blood, that deoxygenated blood, back into our heart so it can go back through the system and become oxygenated. I thought that was a pretty interesting thing. So this is a picture of the arteries, the coronary arteries. You'll notice that obviously there's a lot of coronary arteries. And any one of those can get blocked at any one time. Now the big thicker ones are the ones we don't want to block ever. Oftentimes those will be the widowmakers, right? So those big thicker ones, if we block that, then we know that an entire tree and all the branches no longer have any blood. So what are some of the problems that we can have with our coronary arteries? Remember, our coronary arteries are what supply our heart muscle itself with oxygenated blood. And it needs that oxygenated blood so that way it can continue to contract and push that blood throughout our body. Super important, right? So some of the problems that we can have are something called the cheeseburger effect, is what I like to call it, atherosclerosis. And what happens over time and over the years with poor diet, smoking, diabetes, or just really poor diet, eating high fat foods, we can have something called atherosclerosis. And what happens is our arteries end up getting a plaque buildup right through here. And now over time, that plaque can completely occlude that artery. You can see over here in the picture on the left, this is a real picture of a artery with a bunch of plaque, and it looks like fat because it is fat. It's literally just caked on fat. Now what happens over time though is that plaque builds up in the lining of the artery, and eventually your body starts to believe that that plaque is literally part of its body. It's part of that artery. So if something happens to that plaque, your body starts to freak out a little bit and wants to repair itself. And we'll talk about that in just a second. Okay, so if we allow that cheeseburger effect to continue and we continue to live an unhealthy lifestyle, we can get something called acute coronary syndrome. And it's a syndrome, which means there's multiple things associated with this, okay? And essentially what it is a range of conditions associated with sudden reduced blood flow to the heart. The two that we're going to focus on as angina pectoris and myocardial infarction, which essentially is a heart attack. So those are the two that we're going to focus on because those are the ones that we go on more often, and we actually have a specific protocol that can address this. The first one we're going to talk about is angina. So what is angina? Angina is a disease that's caused by atherosclerosis, okay? So that's the narrowing of the blood vessels. And remember, that's a narrowing of the blood vessels caused by plaque buildup in the arterial walls of the coronary arteries specifically. That's what we're talking about. So normal healthy coronary artery, no plaque buildup, blood is able to flow through that and get to the part of the heart that needs that oxygenated blood, and everything's nice and dandy. As time goes on and we're allowed to continue our unhealthy lifestyle, we start getting that fat buildup, that plaque buildup in our arteries, our coronary arteries, and then we start getting narrowing of that coronary artery, as you can see here. Now, remember that plaque ends up being part of that arterial wall. Your body now believes that that plaque buildup is part of the arterial wall. And so not only does that artery become very narrowed, it actually becomes quite stiff as well. And so now that artery is not able to expand, dilate, or constrict like it normally would if it didn't have any plaque. Can that heart still get its blood? Yes. It's still getting oxygenated blood. The thing is, it's just not getting as much oxygenated blood as it normally would in a normal artery, right? What ends up happening is that heart muscle, or whatever part of the heart that's supposed to be getting that oxygenated blood, gets used to not getting as much oxygenated blood all at once, like it normally would, okay? And again, this happens over years and years and years. And as this continues, we ultimately end up getting a full blockage, a full occlusion of that arterial wall, and no blood is able to get through. So what ends up happening? Well, because of the arteriosclerosis and the narrowing of the blood vessel, that blood isn't able to get through like it should. And as long as we're not doing too much extraneous work, then our heart's happy and we don't have any symptoms whatsoever. Now, what happens when our heart has to work harder than it normally does? So we've, for some reason, decided to run a mile, and we're not used to that. We've gone up a flight of stairs, we're doing some yard work, and now our heart's pumping a little bit faster, which means the heart muscle needs a little bit more oxygen than it normally would. Well, because of the narrowing of the blood vessel, there's not as much oxygen in the blood being able to get to that part of the heart quick enough. And so our heart starts freaking out. and we start seeing typical coronary artery syndrome symptoms. This is going to be the chest pain symptoms, okay? I kind of equate it to breathing through a straw. If you put a straw in your mouth right now and you rest on the couch, you'd probably be breathing just fine, no problem, and you wouldn't feel any distress. But if you keep that straw in your mouth and you go up a couple flight of stairs, you're going to start getting out of breath, especially because you're trying to take all your oxygen in through that little narrowing of that straw. So think of angina the same way. Is there a full occlusion? Nope, not necessarily. But if our heart has to work harder than it normally does, then we're going to have some problems. And as long as the heart can go back to rest, right? So typically, this is a chest pain patient who started having chest pain because they did something strenuous. They rested for a little while, or they've taken some meds, and now the chest pain has gone away. That's angina. Now, I know what you're thinking. If we can have a full occlusion of the bottom, as you can see down here, wouldn't that be considered a heart attack? Now, our body is amazing, and because this takes a long time to take place, our body can start compensating for that. And the way it does that is by using collateral circulation. So what collateral circulation is our blood vessels can start growing more blood vessels to kind of go around occlusions. Now, it really doesn't need to do that in a normal blood vessel, right? If there's no occlusion, then blood's going through just fine. But as we start having narrowing of that blood vessel, and there's parts of the heart here that aren't getting as much oxygen and blood, our heart and the blood vessels start saying, hey, you know what, let's start getting some detours in place in case we need some more blood. So it starts growing more blood vessels around that occlusion. So that way, when we have a full occlusion, as you can see right here on the right, when we have a full occlusion, we have a great collateral circulation tree or branches going right around and supplying the heart with oxygen and blood. And that is why we typically don't have any issues, right? Now, here's a really cool thing. So we say that obviously plaque buildup is bad. And I don't know if you've heard, but doctors oftentimes will say, well, if you start working out, you can really help your heart out. And that's true. We can't ever get rid of the plaque buildup. That's there forever. But the cool thing is if we start working out and start living a healthy lifestyle, that's actually going to promote more collateral circulation to happen throughout our heart. And so that what that means essentially is we're getting pretty much a brand new blood vessel and just taking full-time detours around that occlusion. The next one we're going to talk about is myocardial infarction. Myocardial means heart tissue. Infarction means tissue death. And so what happens with myocardial infarction, this is an actual heart attack, okay? There's part of the heart, there's heart tissue that is no longer getting oxygen and blood, and there's no collateral circulation in place to supply that part of the heart. The reason for this is because there's a blockage that happened in a coronary artery that happened too quickly. We still had that atherosclerosis, but there wasn't a full narrowing of that artery. And now we have a full blockage of that artery because something happened and there's a part of the heart that isn't able to get that blood. So how do we get to the point where we're having a full-blown heart attack, where there's heart muscle that has suddenly stopped getting oxygenated blood? Well, remember the plaque buildup in our arteries? Our body starts believing that that plaque is part of its body. It literally thinks that that plaque is essential to that arterial wall. And so if that plaque becomes injured in any way, shape, or form, our body wants to heal itself. Well, here's the goofy thing about plaque. It's really brittle, and it actually does break quite easily. And so when that plaque, if that plaque ever ruptures or breaks off, our body wants to heal it because it thinks that that's part of the arterial wall. One of the first ways that our body tries to heal itself is by forming a clot to prevent further bleeding and to prevent further injury. And the way that happens is platelets that are in our blood system get recruited into that area. Our body senses that there was an injury in our body or on our body, and it starts recruiting platelets that are already in our blood. Now those platelets get activated and they start going towards that injury site. Now platelets are very sticky, and when they get to the injury site, they essentially start packing on top of each other, trying to plug up that hole or that injury. The other thing that happens is our body starts producing more platelets. So not only does it utilize the platelets that are already in our blood, but it actually starts producing more platelets as well because it really wants to fix itself quickly. And as those platelets start packing on top of each other and more get formed and start packing on top of that, we quickly become quite narrowed. So that artery that was already narrowed due to the atherosclerosis now is fully occluded, and it happened very quickly because that clot got way too big. So how do we assess a chest pain patient? I'll admit that this can be really hard to do, and I understand the frustration that people may be having when assessing chest pain patients. And I think the frustration comes with, all right, we assess this patient, but based off of my assessment, now I have to figure out, do I treat this patient with a cardiac protocol, or do I not treat this patient with cardiac protocol? And I admit that can be really, really hard to do. So let's talk about how do we assess these patients. First off, we need to understand that we'll never be able to say with 100% certainty that a patient isn't having a cardiac issue, okay? We can't do that. What we can say is we are kind of sure, and we know for a fact they're not having musculoskeletal issues, breathing issues, or other type of issues, okay? So essentially what we're doing is we're ruling out everything else until we get to the point where we just can't rule out cardiac. And when we get to that point, that's when we start treating for cardiac chest pain or for a cardiac issue. All right, so how do we rule out things? The easiest way and the best tool we have to rule out things is the OPQRST questions, okay? Now let's break this down one by one. So onset, what was the patient doing when the pain started? Were they sleeping? Were they lifting heavy objects? Were they trying to start a lawnmower or a weed whip and it just wasn't starting? Did they get in a fight? Did they fall yesterday and then they woke up and they started having chest pain? What started this chest pain to begin with? That's super important to understand, okay? The next is provocation. So this is kind of a two-way question. What makes the pain worse, but also what makes it better? And this is a goofy question. Remember, when you assess a patient, you need to be hands-on. So it's not just good enough saying, hey, does anything make the pain better or worse? You actually need to make them do it, because sometimes people don't try to make the pain better or worse, right? It just hurts. Pain is pain, right? And so a good way to rule out cardiac or rule out musculoskeletal is to ask them, hey, does anything make it better or worse? If you were to take a deep breath, does that make it worse or better? If you lift up your arms and move them around, does that make it worse or better? If I were to press on your chest, does that make it worse or better? And now, if you press on their chest and that makes the pain worse, if they move their arms and that makes the pain worse, if they take a deep breath and that makes the pain worse, then you should be pretty sure that this is probably not cardiac. This is either musculoskeletal or this is respiratory, right? But if they do all those things and none of that makes it better or worse, then the likelihood that it's musculoskeletal or respiratory is quite low, and the likelihood that it's cardiac is quite high. Again, we can't say for 100%, but at least we can say it's more towards the cardiac. We're leaning more towards the cardiac than we're leaning towards the musculoskeletal or respiratory, okay? So the next one is quality. This is where a lot of people have a hard time, the quality. What does the pain feel like? Don't get caught up on, well, it's pain, or, well, they didn't say it was sharp, or they didn't say it was a pressure, they didn't say it was an elephant sitting on my chest. Understand that the old, hey, chest pain was a hard pressure or a heavy pressure that radiated to the left arm, to the left jaw, that, the stereotypical cardiac issue, that's out the window, okay? There is no longer a stereotypical chest pain patient, okay? Patients are patients, and every patient's a little bit different, and they may present just a little bit different, okay? So don't get caught up on that. And again, I understand the frustration. I can see where that could be hard, but it's up to your good clinical judgment to figure out if they're having or can deduce that they may be having a cardiac event, okay? So the quality. Hey, what does a pain feel like? Paint me a picture of how that pain feels like. Use as many descriptive words as you can to help me understand your pain, okay? Now, there's some people that are just going to say, hey, it just hurts, okay? Pain is pain and it just hurts. I understand that, but we really need to understand what your pain feels like. So if a patient gets to the point where they just cannot tell you, what their pain feels like, or they just won't tell you what the pain feels like, then give them a bunch of options and make them pick one. Okay, I understand you're having a hard time telling me or describing your pain, so I'm going to give you a bunch of options and just pick whatever fits the best, okay? Is it sharp? Is it a shooting pain? Is it a pressure? Is it a squeezing? Okay, is it a burning type pain? Give them a bunch of options so they can pick from, and just whatever one fits the best. And then just let ALS know that, hey, they weren't really able to describe their pain. I gave them these options and they said this one fit the best. Okay, we're going to do the best we can with what we have. Understand that, again, there's no longer a typical chest pain presentation, right? The pressure on the chest is not necessarily a typical chest pain presentation. Will they have it? Maybe, but they may not have that either, okay? So don't get tunnel vision that, hey, they didn't say it was a pressure on their chest, or they didn't say that it was a stabbing pain, so I don't think it's cardiac, okay? Don't get tunnel vision. You need to look at the entire patient presentation, the patient history, and the rest of your assessment questions to determine whether or not it may or may not be cardiac, okay? The next one is radiation. Does this pain move anywhere? I understand that the pain started in your chest. Does it go anywhere else in your body? Don't necessarily give them where it might go because we don't want to give them any ideas. A lot of patients have probably already WebMD'd this prior to our arrival, right? So they already know the key words, the buzzwords, right? So just ask them, hey, does your pain go anywhere else in your body? Do you notice it anywhere else in your body? They may say your arms, armpits, back, scapula, neck, jaw, even teeth, right? I've had a chest pain patient who his only other complaint other than the chest pain was it felt like he had a tooth infection. And that was because of the radiating pain. Okay, that was the referred pain. So that's as much as we have to go with the radiation. So the severity. On a scale of 1 to 10, 10 being the worst pain or worst discomfort in the world, how could you rate your pain? This is another one where patients typically have a hard time giving you a good number. Please understand that I don't care what their number is specifically. If you give them a range of 1 to 10 and they give you 13, that's perfectly fine with me. I don't care what the number is. All I care is that they give me a number. And the reason for that is because we're going to start treating this patient. And after we start treating this patient, I'm going to ask them again, hey, now that I've treated you on a scale of 1 to 10, 10 being the worst, you gave me a 13 last time, what's your pain at now? If they give you 11 or a 12, yeah, it's out of the range, but you know that it's still a number and it's less than the first number, so we know we're going in the right direction, right? The whole point of the severity, the pain scale, is just to determine if our treatment is working in the first place, okay? Because I think we can all agree that there's patients who say they're a 10 out of 10 chest pain in general, and they're walking, talking, and even laughing, right? And then we have patients who are 1 out of 10 and they may be crying, right? People are unreliable. Really, it's not the fact that are they really in pain or not in pain. All I want to know is my treatment working? I gave you a 1 to 10 scale, you gave me a 13, I treated you, and now you're giving me a 12. Either my treatment's working or it's resolving by itself, but either way, we're going in the right direction. I hope that makes sense. The next one is time. How long has this been going on? And also something that we forget to ask is, has this pain been constant? Have these symptoms been constant? Or have they come and go throughout the day? Do you notice them in certain parts of the day? Or did you notice them when you were doing something specific, right? Maybe it started when they lifted something heavy, and it kind of went away, but when they were going up a flight of stairs, it started back up again, okay? So ask that question. And another really, really, really good question to ask when you're asking all the sample question is, have you had this pain before? Because if they say, yes, I had this pain back in 2013 when I had a heart attack and triple bypass, and this feels exactly like that, well, shoot, they kind of did all the work for us. We're still going to ask all the OPQRST questions, but now our index of suspicion is way higher, right? And now we're going to definitely want to start treating for a cardiac event, right? So, again, understand that the OPQRST questions are used to rule out certain things. We can never 100% certainty rule in cardiac, but we can rule enough things out where we can say, well, all we have less is cardiac, and so we're going to start treating that way. Okay, let's talk about some of the signs and symptoms that we may see. Kind of alluded to it on the OPQRST slide that there's no true hallmark sign of cardiac chest pain anymore, okay? I understand that everyone was taught, I was taught that, you know, the chest pressure that radiates down the left arm and up to the jaw was your hallmark sign of chest pain. But there's so many things that go into a cardiac event, and every patient is a little bit different and feels things just a little bit different, okay? So again, it's up to our good clinical judgment and our good assessment skills to figure out if they're having, or to deduce that they may be having a cardiac event, okay? Understand though that patients who are having certain symptoms and fit a certain demographic are probably having a cardiac event, okay? So consider a diabetic, an obese patient, something that maybe you've heard in school, a female who's obese, over 40, right? Or they're at higher risk of having a heart attack. And so if we go to that type of patient, a certain demographic, and they're having certain symptoms, we can probably deduce that they may be having a cardiac event. Okay, so some of the signs and symptoms. Chest pain or pressure. Don't get caught up on the whole pain, pressure, stabbing thing, but they're going to have some sort of discomfort, okay? We may see some nausea, vomiting, shortness of breath, diaphoresis, so sweating, neck or jaw pain. They may have teeth pain, arm pain, and don't get caught up on, well, they're having the right-sided arm pain. They can radiate over there as well, okay? They may just have armpit pain. They may have back pain. Those are all symptoms or signs of a cardiac event, okay? Again, by themselves they're not enough, but with the OPQRST questions, the signs and symptoms, and a good history, we can probably deduce that they may or may not be having a cardiac event, okay? And based off of that, we're going to hopefully treat appropriately. Okay, so here we have the chest pain acute coronary syndrome protocol that's specific to Kent County. We're going to break down this protocol so we can understand what our treatment is and why we're doing it. So number one is just our general pre-hospital care protocol. There's a specific protocol on how we need to care for every patient, general patient. It's a pretty good protocol. I encourage you to go look at it. It has some good assessment skills and has some good numbers that we want to look for when doing vitals. But for now, we're going to go ahead and skip past it. Again, I encourage you to go look at it, but for now, for this purpose, we're going to go ahead and skip past it. So number two, you'll notice that if we're unable to get a pulse oximetry on a patient, they want us to give at least 4 liters per minute. Now, via nasal cannula. Now, something to keep in mind. If we're unable to get a pulse oximetry on a patient, and the patient looks like they're having a hard time breathing, they're probably going to need more than 4 liters per minute. Protocols can't paint every picture, right? They're not black and white. There's a lot of gray in them, and they really, really rely on our good clinical judgment. So if we get to a patient and we're not able to get a pulse ox on them, and they look like they're really working to breathe, please treat them like a patient who's really working to breathe, whether that means nasal cannula, non-rebreather, a CPAP, or a nebulizer. Treat them appropriately, okay? Now, you'll notice that if we can get a pulse ox of 94% or better, then the patient may not necessarily require any oxygen. Again, that's assuming that the patient isn't working to breathe hard, isn't working to maintain that 94%. So assuming we have a patient that isn't working to breathe and isn't working hard to maintain that 94%, we have a patient who's breathing appropriately, and they have a 94% or better oxygen saturation, and their vitals are okay, then we do not need to give them any oxygen. And the reason is oxygen has a lot of free radicals in it, okay? And what those do is those can actually break down cells, or cell walls specifically. So when we have a part of the heart that is not getting oxygenated blood, those cells start kind of going into starvation mode, okay? And they can kind of survive for a period of time, but after a while they start dying off. So they're going into the starvation mode, and they start getting used to not getting any oxygen. They start using other methods to maintain their existence, essentially, until finally they get to the point where they just can't do that any longer. Now, when the patient gets to the hospital, they're either going to get some medications to bust up that clot, or they're going to get a cath in the cath lab to get that clot out. And when that oxygen-rich blood now rushes into that artery, it's going to go to those heart cells that were starving of oxygen. And unfortunately, because they were starving for oxygen for so long, they need some time to start adjusting for now this oxygenated blood. And if we bombard them with too much oxygen, with too many free radicals in them, those free radicals will start breaking down those heart cells, and essentially will start killing all those heart cells. And so it's super important to make sure that hey, if they're maintaining a good oxygen saturation, they're not working hard to breathe, then let's go ahead and just leave them be. Let's not bombard their body with a bunch of oxygen, because when they do become reperfused, that means now that blood's going through, that's going to cause a lot of issues to those heart cells that we're not getting any kind of oxygen in blood. Okay, number three. This is where really things get a little difficult, where we need to make a decision whether or not a patient's going to meet the chest pain protocol or they don't meet a chest pain protocol, right? So at this point now we need to be able to treat a patient appropriately. So number three is, if the patient meets chest pain protocol, we now are required to give the patient aspirin. Now you'll notice here it says assist the patient using their own aspirin. That's true for medical first responders. Kent County has allowed us to carry our own aspirin, to give the patient aspirin without having to use their aspirin, okay? And that's probably better anyways. We don't know if the patient's aspirin is expired, if it's any good, if it's been exposed to too much moisture, and etc., okay? So we get to a patient, we have deduced that they may be having a cardiac event. We have ruled out all the other issues that could potentially be causing similar type symptoms, and now we need to treat appropriately. We've either given them oxygen or not given them oxygen, and now it gets to the point where now we have to give them aspirin. So the importance of aspirin is really high, and I really feel that aspirin is a life-saving drug, because aspirin can stop a heart attack in its tracks. Remember how I said a heart attack is formed, right? Platelet breaks off, body starts trying to heal itself and starts making a clot, and all those platelets start piling on top of each other, right? And also your body starts producing more platelets, right? So if we're able to give patient aspirin at the full dose, 325 milligrams, full dose aspirin, as soon as they start having chest pain or shortly thereafter, we can now prevent that clot from getting bigger, okay? And it's super important that we give that aspirin. So people sometimes ask, well, hey, you know what, they took aspirin in the morning, 8 o'clock in the morning, and now it's 12:30 in the afternoon, and they just start having chest pain. Do I need to give them aspirin? Yes, you have to give them aspirin. And the reason is when your body starts producing new platelets, those new platelets are going to be sticky. They're going to be able to pile on top of those other platelets there. Now, the old platelets that are in his body that were formed after he took his aspirin at 8 o'clock, those ones are slippery. Those aren't going to be effective, and we're okay with that. But remember, your body's always making more platelets, right? Platelets die off, and your body makes more. And then when your body detects an injury, it all of a sudden starts making a lot more, right? So we want to give aspirin so that way any new platelet that's being formed is going to be formed slippery, okay? And we can really slow down and prevent the growth of that clot. It's important though that we give the full dose. So say we have a patient who at 12:30 started having chest pain and they took one baby aspirin prior to our arrival. Some dispatchers advise that the patient to take an aspirin, okay? So they took one baby aspirin prior to arrival, we get on scene and they say, yep, I've taken one baby aspirin. Okay, well, they don't have the full dose yet, right? So now it's up to us to, again, ask all the appropriate questions, get a good set of vitals, and then once we've determined that we're going to follow the chest pain protocol, let's give them 3 more baby aspirin to really round up that 325 milligram, okay? That's the best practice. That's what we need to do. Make sure that the patient chews up the aspirin and then swallows it. If they've taken a regular aspirin that was coated, it's not going to be as effective. Is it still going to work? Yes. But typically that takes a good 30 plus minutes for it to get into the system and get up to the therapeutic range, where if we can chew it and then swallow it, that's really going to absorb quicker in the vascular system and get into the therapeutic range within minutes. So that's really the gold standard. I hope you all enjoyed the presentation. If you have any questions, comments, or concerns, please don't hesitate to reach out. If you have any suggestions for other topics, please let me know. I know this really doesn't take the place of classroom presentations. I really enjoy classroom presentations because we can really talk as a class, and I can kind of bounce ideas and topics off other people. I feel like people learn really well that way, but I think this is a good alternative. Please let me know how else we can improve this process, and we'll see you next time.